Good morning. I'm not a clinician or a doctor like many of you, and I'm not an academic. I practice the dark arts of journalism. Hopefully I can persuade you that some of us are okay. I've been at the BBC for 15 years, based in London. I'm shortly leaving, not pushing. I've not been pushed. I've chosen to leave. But during that time, I've sort of specialised in analytical and investigative journalism. The last 4.5 years, not solely, but looking at the standard of care being provided to gender questioning youth in England, and that culminated in a book, which is why I'm here. There are some aspects of the Tavistock's Gender Identity Development Service, or GIDS, that are quite specific to the UK. For example, we have a public health system, the NHS, very different to here, and GIDS is the only national provider of youth gender care, therefore a little easier to monitor. I'd like to think we have a strong, impartial press who asked important questions of the service and were able to do so in a slightly less toxic environment. But most importantly, there were clinicians who were brave enough to speak out about what they saw going wrong, even when that was at personal and professional cost to them. But I do believe that there are some key themes here that apply universally and from which lessons can be learned. Just before I start on those, though, I just want to read you the last 3 sentences of the opening chapter of Time to Think, which I think sums up my approach to this, because for me, it's about healthcare, really. This is not a story which denies trans identities, nor that argues trans people deserve to lead anything other than happy lives, free of harassment, with access to good healthcare. This is a story about the underlying safety of an NHS service, the adequacy of the care it provides, and its use of poorly evidenced treatments on some of the most vulnerable young people in society, and how so many people sat back, watched, and did nothing. So I'm going to break down some of the themes in those sentences into hopefully some more tangible lessons. So where better to start than when new evidence emerges that challenges what you thought you knew, be prepared to change direction. Across Europe, at least, I think there is agreement now that the science in this area is unsettled. It's overpopulated with small, poor quality studies, and it's often not possible to draw definitive conclusions on the benefits or harms of the medical treatments used to help transition. Many of the studies that claim to show mental health benefits of puberty blockers have been heavily critiqued, sometimes by people in this room, and have significant methodological flaws. Systematic reviews of the evidence base undertaken in England, Sweden, and Finland have all found it wanting, as we've heard. So what was GIDS' approach to providing evidence-based treatment? Well, they started off really with the right idea: to try to test the pioneering Dutch findings of the benefits of early puberty blockade, which we've been hearing about. GIDS and their endocrine colleagues at University College London hospitals tried to carry out their own research to try to add to the evidence base, which actually was unanimously accepted at the time as being quite limited. Promising, but limited. And so beginning in 2011, 44 young people were enrolled onto a study, and they could start treatment at the age of 12. And up to that point, it was 16 in England, and they had to meet certain criteria. It's really what happened next, and I think it's fair to say what happened in gender clinics around the world, that's so striking. So GIDS didn't wait for the data from that study to emerge before changing practice anyway. And from mid-2014, puberty blockers became available to younger children as standard clinical practice, outside of research setting, no follow-up. At the same time, they moved to a stage, not age approach, where access to blockers was dictated by a child's stage of puberty, in this case, Tanner stage 2, so really early puberty. So just to point out, to show you why there was no data, the last participant only joined the study in April 2014. 6 months before that, only 23 young people had actually started treatment with the blocker. There really couldn't be, and there weren't, any meaningful data upon which to base that decision. So what was behind it? Well, one clinician from the time told me it was based largely on 2 things: Firstly, the Dutch were doing it, and secondly, Mermaids, which is a group that supports young people wanting to transition, wanted it to happen. A slightly more charitable explanation is given by Dr. Natasha Prescott, who was also at GIDS at that time. It stemmed, she said, from a desire to help. There was a real empathy for these distressed young people, and here was a potential solution to help with that distress. So the decision was well-meaning, but, as Dr. Prescott put it, lots of things can be well-meaning but ill-informed. Now, at the same time this change in treatment took place, there was an enormous increase in the referrals to GIDS, as there were across the globe. The numbers had been increasing by 50% per year from 2009, and then between 2014, 15, and 15, 16, they doubled. And in 5 years, they went from 139 to 1,419. So, yeah, more than 10 times as many. And then what you can see here is that the sex ratio also shifted dramatically too, from 2/3 natal or assigned male historically to 2/3 female by 2015. And on top of that, most were girls whose gender-related distress had begun after the onset of puberty and who often had complex needs. Often they might be contending with depression, anxiety, eating disorders, histories of abuse and trauma. And that shift, as we've heard over the last couple of days, has been witnessed in gender clinics across the world. But you can see that all the categories go up, but the most dramatic increase is in the adolescent females. Now, as we've heard many times, the young people in the Dutch studies, which had pioneered this early blocking of puberty, were very different. I'm not sure we have to go through these in huge amount of detail, as we've heard them many times, but they had to have experienced gender dysphoria from childhood, which had worsened with the onset of puberty. They needed to be living in a supportive family setting, and crucially, they had to be psychologically stable with no other major mental health problems. The young people referred to GIDS were not the young people of the Dutch studies. Now, here is Dr. Bernadette Wren, who's on your far left. It's a terribly filmed piece of parliamentary footage. And she's talking to the UK Parliament in 2015, and Bernadette was kind of the number 2 at GIDS, if you like.
We're not having the sort of more what you might see as the ones who are in the very highly regarded Dutch study, which is this group of now 55 young people being tracked over time, who lifelong GIDS, very supportive family, very few associated difficulties. They represent a very small, that sort of profile is a very small proportion of our young people. The range, the terms of gender binary, we're having more and more young people coming forward with really quite disrupted attachment histories, more looked after children. You know, on a typical referral day, we are really concerned about the complexity, I suppose, of many of the young people coming forward.
Right, so couldn't be much clearer. Not the Dutch kids. And despite the acknowledgement there from Dr. Wren that only a very small proportion of those referred to GIDS were like those for whom this medical pathway was designed, Wren then explained that many of them received puberty blockers anyway.
I work in a service where most of the young people who wish for it, for all of the, most young people, a lot of young people have physical intervention, and anybody who wants it, we have no record of turning people down for physical intervention. But what we offer is not just physical intervention.
So no record of turning anybody down for physical intervention. Now, Dr. Polly Carmichael, who was and is still the head of GIDS, she has been since 2009, was even more explicit about this. We offer assessment and treatment not just to those young people who are identifiably resilient and for whom there is an evidence base for a likely successful outcome. We have carefully extended our program to offer physical intervention to those who have a range of psychosocial and psychiatric difficulties, including young people with autism and learning disabilities and young people who are looked after. We have felt that these young people have a right to be considered for these potentially life-enhancing treatments. So GIDS were open about this. They were routinely referring young people at this point in time for puberty blockers who were expressly ruled out by the Dutch studies. Well-meaning, perhaps, but based on feeling, not on evidence. By 2016, all of those taking part in that early intervention study had been receiving puberty blockers for at least a year. And Polly Carmichael was explicit about the findings to colleagues working in this field.
So in terms of our early intervention, I guess the other thing is that our results have been different to the Dutch. We're about to publish these, and we haven't seen any change in terms of psychological well-being and so on.
We're about to publish these, but actually they weren't published for another 5 years. But by now, GIDS had routinely been referring anyone who wanted it for puberty blockers for 2 years, 162 under 15s by that point, without waiting to see whether their data supported it. And as Dr. Carmichael says, the early data didn't support it. The GIDS team received a presentation on these findings around the same time, and they learned that not only had the children's well-being not improved, for some it had got worse, but also that every single one who was old enough had chosen to continue onto hormones. Now, for some, like Dr. Anna Hutchinson, who you've heard from already, this exploded the idea that the blocker was providing time to think. Because as she put it, what are the chances of 100% of people, young people at that, offered time to think and thinking the same thing? And to many, it felt as if puberty blockers were not neutral, therefore, but rather the beginning of a pathway. And we heard from our European colleagues yesterday, I think, sort of acknowledging that, not providing time to think, but rather the end of thinking and exploring. And that is something that Dr. Carmichael acknowledged herself at that same 2016 WPATH conference we've just heard her at. Of the 162 young people who'd started treatment by this point, a little over 1%, had stopped.
So I guess there is a question about why why none stop once they've started on the blocker, more or less. And so I guess that begs the question that either we're not putting forward enough young people for this, that there are some people who would benefit from this who are missing out on this treatment, or that in some way this treatment in and of itself may have an impact and set people on a path.
Equipped with the evidence that for this group of young people, overwhelmingly female, with complex associated difficulties whose gender distress had begun in adolescence, puberty blockers didn't appear to be working in the way the service had hoped, there could have been a change in direction, as we've heard from Finland. But, as so many GIDS staff told me, everything had changed, but nothing changed. While some individual clinicians did begin to practice very, very differently and more cautiously, there was no major service level change. When the study was formally published in 2021, it said they'd identified no changes in psychological function, quality of life, or degree of gender dysphoria. And there's been a recent reanalysis, which several people have alluded to, of those data, which suggests that something rather different could be the case. I reported this for the BBC just a couple of weeks ago. When the individual trajectories of the children involved are analysed, rather than taking a group average, as the original study did, the majority of those young people saw a significant impact on their mental health after 12 months on blockers. 34% had deteriorated, 29% had improved, 37% had seen no change at all, so roughly a third. Now, because of the way that original study was designed, as is every study in this field, without any control group, we can't attribute these changes directly to the blocker anyway, either the original findings or this. But this reanalysis certainly provides food for thought, I think. Now, there are other reasons for blocking puberty: to make transition in adulthood easier with potentially fewer invasive surgeries, for example. But this was never the rationale put forward by GIDS. So I've spent a lot of time on lesson one. I promise the others won't be as long, but really they all follow from that core point, that when the evidence changes, be prepared to change practice. So lesson two, offer more than one treatment pathway. Just as young people had arrived at their gender difficulties in different ways, sometimes after a traumatic incident or homophobic bullying, it seemed obvious to many GIDS clinicians that there were likely different ways out of it too. I have spoken to those who describe puberty blockers and subsequent hormones as life-saving, who are happy trans adults, and I do not question their experience. Equally, There have been young people who've transitioned, who've been harmed, and instead needed less invasive options. Services must offer different clinical pathways to meet the needs of all young people. Now, one thing that's so striking about the story of GIDS is the number of missed opportunities to do things differently, to improve the care given to this often vulnerable and distressed group of young people, and just how far back those opportunities go. So this is lesson 3. In 2005, Sue Evans was the first person to raise concerns that some clinicians at the service appeared to be referring young people for physical treatments too quickly. Those concerns were thoroughly investigated by the then medical director. And in short, he said, we've got all this uncertainty. Let's be the best in the world at this. Let's do the research. Let's follow up our patients. Let's conduct clinical audits. Let's look at whether the young people on the blocker actually are taking that time to explore their identity. But the service didn't do it. Another opportunity came a decade later, in 2015, when an independent consultant was brought in to try to help GIDS cope with those ever-increasing referrals. Her report described staff under intense pressure, which they were, struggling to provide the best care they could for the patients. And she said the current model of working is unsustainable. It recommended that GIDS, quote, take the courageous and realistic action of capping the number of referrals immediately. So in other words, the service should pause, even if just for a short period of time, to reshape, rethink what it could offer and to whom. It didn't happen. Those findings were shared with only a small group of senior staff. GIDS could have been the first team to develop a new, more nuanced assessment that was acknowledging that this cohort of young people was changing and that maybe they needed different treatments. Dr. Hutchinson told me in one of our many interviews, we could have changed the whole story of what was going on. Not just have been a better clinical service, but actually had an impact on global practice and society. A year later, as I've mentioned, GIDS's data showed that young people's well-being was not improving while on the blocker, and yet no changes. Next, in the summer of 2018, a report by adult psychiatrist Dr. David Bell laid out in quite devastating detail the very serious concerns of 10 GIDS clinicians, and that was around a quarter of the staff working in the London base at that time. And these clinicians relayed to him how some children were being referred for physical interventions after just an hour or two, that there was pressure to process referrals quickly because there were so many of them, and yet these were some of the most vulnerable and traumatized young people they had ever worked with. He heard how staff who'd raised concerns were pushed out, that a small number of children appeared to be being pushed by their parents to pursue a trans identity rather than coming out as gay, and that some families seemed more invested in the transition than the young person themselves. Ultimately, Dr. Bell's report argued that care at GIDS, the care that they were providing, wasn't always safe. Now, that report was shared with the most senior figures in the Tavistock, which is the trust that houses GIDS, and the wider NHS that commissioned it, but fundamental reform didn't follow. Lesson 4, keep a professional distance from interest groups. Almost every clinician I've spoken with, regardless of their views on GIDS itself, talked about the influence of trans support groups on the work and atmosphere of the service. One told me we were answering to mermaids. That's the name of one group. But Mermaids was and is a group very supportive of medical transition in childhood with minimal assessment beforehand. GIDS denies that any outside group directly influenced clinical practice. But I've been told that the head of Mermaids, Susie Green, would sometimes make requests for a young person's clinician to be changed if they weren't agreeing to physical interventions quickly enough, and that would be agreed to. Green was in regular contact with the head of GIDS and board-level figures in the Tavistock, and she was able to refer children directly to GIDS as well, sometimes after their own GP, what you might call a primary care physician, I believe, in the US, had refused to do so. For those who'd worked in other clinical services, this level of influence by patient groups, not just mermaids, was surprising and novel. It seemed that GIDS was unable to hold its ground and explain what they were doing instead of bowing to pressure. And it seems from what we've heard in the last couple of days that a similar dynamic plays out in other countries with youth gender clinics. But obviously, these groups have a right to their view, but the demands of specialist interest groups do not always align with the best interests of children or the best available evidence. And while it's certainly not the case that these groups got everything they asked for, they really didn't, their presence was felt almost constantly, clinicians say. And it was pressure in part from these groups that first took GIDS down a path of providing physical interventions at much younger ages without a strong evidence base. And some told me that a fear of a backlash from these same groups prevented the service changing direction when it should have. Here's what I mean by that. So I've been told about this reluctance or fear even to put new information on paper at GIDS because anything put on paper will be picked up and scrutinised, and these outside groups then might accuse the service of scaremongering. So here are two specific examples of things that should have been passed on to every single relevant family, but that weren't. So first, that finding that everyone who had begun treatment with puberty blockers had continued on to cross-sex or gender-affirming hormones. The second concerns a visit to the GIDS team in November 2016 from one of the UK's most experienced gender-affirming surgeons. Now, during this meeting, staff were told about the surgical problems that can occur if puberty is blocked too early in boys. There isn't enough penile skin to perform a vaginoplasty in the safest and most effective way. Instead, a riskier procedure with less stable results has to be carried out. Now, this is widely acknowledged in this field, and here's the current head of WPATH, Dr. Marcy Bowers, talking about it at Duke University last year. I couldn't zoom in on her.
The two problems that frankly I became concerned about was the lack of skin for in creating a female vulva. So that's troubling, but that we got better techniques. We've worked around it. Still, the majority of people are very, very happy with their outcomes, but it probably could be better, and if there was more skin. So how can we get that? How can we get what we need to do surgically without making somebody go through a secondary a puberty that they don't want to go through?
The second problem, in case you're wondering, is whether natal males blocked at Tanner stage 2 could ever achieve orgasm as an adult. But back to GIDS in 2016, and to those listening, this was incredibly important information. And almost immediately, one clinician drafted an information leaflet that could be passed on to the relevant families during assessments. It was approved for accuracy and the language by that surgeon that had visited, but it wasn't given the green light from GIDS director Polly Carmichael. And that leaflet explained how the Dutch team had found that 80% of their early intervention patients had insufficient suitable skin and had needed to use segments of their bowel for surgery instead. Now, everyone I've spoken to who listened to that presentation did, from that moment on, pass it on. But with both of these examples, nothing was written down. The knowledge wasn't passed on to new members of staff who joined, and they simply couldn't pass on what they didn't know. It wasn't until May 2019, 2.5 years later, that written information was routinely provided on those possible implications for surgery. Lesson 5. Young people and their families must be given all the information available about physical interventions, the risks and benefits, and what is still unknown, in order to provide fully informed consent. Now, those will inevitably be detailed and difficult conversations. The 6th lesson is to listen to staff. The people who worked at GIDS didn't keep these serious worries to themselves, and concerns were raised again and again and again, and there's a paper trail that shows it. The issue really was how they were handled, and two things would generally happen. There would be a lot of talk, but no action, or those who raised these concerns would be labelled as troublemakers and often scapegoated. Most who spoke out and those who helped them or amplified those concerns had to leave the Tavistock in one way or another. According to one senior clinician, anyone who spoke out was made to feel hysterical in some way. And they said, the more anxious and worried you became, the more it was framed that you weren't really someone who could handle it. It was a brilliant way to divert it away from what we were actually doing, which was changing children's bodies. Safe clinical services listen to staff when they raise clinical or safeguarding concerns, because that is what these concerns were. Not transphobia, safeguarding and clinical concerns. Gender clinics must foster an environment where people are free to speak up without fear of retribution. And finally, and very much really where we started, clinics must collect robust data and conduct proper research. It's not acceptable that this group of children and young people have a lower standard of care, follow-up and evidence-based treatment than others. Research is needed which monitors young people and records their long-term outcomes. When the Tavistock was taken to the High Court in England, that's one of the highest courts in the land, by Keira Bell, it appeared that it had collected next to no meaningful data in more than 30 years. The court expressed its surprise, I think that's a typical British understatement, at GIDS's inability to say how many children had been referred for puberty blockers, nor the age or sex of those referred. These numbers, despite trying, have never been released. The service either doesn't know or doesn't want the public to know. I estimate it about 1,500, but that's from what we have in the public domain. And we know next to nothing about how the 10,000 or so young people who've been seen by GIDS have fared, both those who started a medical transition and those who didn't. Data must be collected to inform best practice. So just to recap, some of the lessons that I think can be learned from the rise and fall of the world's largest gender clinic for children. We need to respond to changing evidence, offer more than one treatment pathway, seize the opportunities to change, keep a professional distance from interest groups, be honest about what we do and don't know, listen to staff, and collect robust data and conduct proper research. I think whatever anyone in this room believes is the best way to help this group of young people, I think it's safe to assume that everyone wants what is best for them. Many want to strike a delicate balance, an approach with enough caution to allow those who will thrive as transgender adults to benefit, but also protect those who'd be better off on a different non-medical path. Others question whether it will ever be possible to know in advance whether medical transition will help or harm any given child. Former GIDS staff have started these really important conversations, and it's time for others to continue them, because we have to get this right, and we have to get it right because it's about children, and few things can be more important than their future health and happiness. Thank you.